Spinal alignment or malalignment is something that has become quite the topic in spinal surgery over the last few years. This is predominantly because of our increased understanding of the function of the spine and the work of the curves of the spine in holding the head over the pelvis. Generally speaking, our body attempts to put our head over our pelvis while exerting the minimum amount of energy. If through one cause or another, the head starts tilting one way or another, for example, to the front or to the side, the spine and the trunk, generally speaking, will attempt to compensate for this malalignment. And what that then causes is fatigue and fatigue-related pain, which is the main symptom associated with sagittal or coronal spinal malalignment. The commonest cause in adults for malalignment is degeneration. And because disc degeneration is something that can occur in an asymmetric way, i.e., the discs can collapse on one side more than another, or slip over one another in an abnormal way, they can lead to the remainder of the spine reacting to this by curving, twisting, or bending in a way that will require additional energy exerted to try and keep the head over the pelvis. And that is a painful situation in its own right. Symptoms from spinal malalignment are occasionally difficult to interpret because they're predominantly back pain. However, it's the character of the back pain that is important in situations like this. We know that the spine tries to put the head in a position without the body exerting any energy. If the body starts exerting energy, then the trunk, particularly the muscles around the base of the spine, start firing or working much more than they normally would have. And that causes pain in the areas around the center of the spine, particularly in the bottom part of the spine. And because it's a fatigue type of pain, it tends to be something that gets worse over the course of the day and is usually associated with a deterioration in the overall position of the trunk as time passes by. Realizing that the spine is out of alignment is, for the most part, easy because it's a significant change in the overall position of the trunk when one is standing. And that can be something observed in a mirror or while even sitting, as one might hold their trunk sideways, or through the requirement of a more supportive walking aid, like the progressive requirement of crutches or a walking frame because of the maldistribution of the person's body weight. Spinal malalignment, if symptomatic, and if the patient is fit for it, can be done. It is one of the more involving, technically demanding, and significant spinal interventions that we have, and requires a substantial amount of reconstructive surgery. But the evidence published around it suggests that patients are generally satisfied with their outcomes and are happy that they have had it done, despite the fact that its complication profile is larger and more significant than simpler spinal procedures. To align the spine, we tend to, generally speaking, look at the deformity that caused the malalignment to see whether or not it's something that is mobile or fixed. And the treatment for the malalignment is then dependent on the nature of that deformity. But generally speaking, it involves putting a significant number of screws, the utilization of a rods that would bring the spine into a more normal position, and the use of building blocks called cages between the vertebral bodies to support the weight of the spine as it's moved. In certain situations, particularly in the setting of a fixed spinal deformity, we are obliged to cut the spine to bend it or move it. And those complex procedures are called osteotomies. The risk profile of spinal alignment surgery is quite substantial. 80% of the patients who undergo the surgery are expected to have a complication. Now, when those figures are plotted, they are quite large, but most of those complications are minor. Major complications, such as neurologic injury, such as significant blood loss or metalwork failure, are less common, but their chance of happening is still not insignificant at 1 in 4. That's why those procedures should be done by a practiced spinal surgeon who has an experience in this field, and they should also be done for the right indication in somebody who understands those risks very well. The vast majority of patients who undergo spinal realignment surgery are satisfied and their patient-reported outcomes are good. It doesn't, however, make the risk profile of the surgery any less. It just focuses the mind on the choices that needs to be made before a surgical intervention is taken. And that's both on the side of the surgeon and the patient.